So hello everybody. So we'll start our Swiss session to try to stay on time. Could you have a seat? Take a seat, please. So just an announcement, at the end of that day, don't forget to take part in room D at 5:20 p.m. to a supervised drug consumption facilities examining the paradox. And tomorrow morning at 8 o'clock, we'll have an AbbVie-sponsored morning symposium with issue Mindshift for HCV, Uniting Treatment, Addiction Recovery, and Mental Well-being for People Who Use Drugs. And so my colleague Alberto Morija and myself, Pascal de la Santa, are very pleased to chair this session in the afternoon. And we are both GPs, Alberto in Italian-speaking part of Switzerland, and myself here in Geneva. And I'm very pleased this afternoon to welcome Professor Barbara Bruce, who has worked for so many years, about 30 years, in addiction field in Switzerland. She was a former head of the dependencies unit of the primary care division at the Geneva University Hospitals. She is also vice president of the Swiss Federal Commission for Addiction Issues and of the Swiss Society for Cannabis in Medicine. So please, Barbara.
Thank you. Thank you very much, Pascal. Thank you very much to the organizers to invite me to talk something, and I thought, oh no, again, we're going to talk about Switzerland. It's boring, you must all know. But so I try to focus a little bit more on different things. But first, I would like to welcome you in Geneva. And since we are a little bit, getting back into the past, I found this cartoon again, which was from 2001 in the local newspaper at the time of the opening of the Quai Neuf facility, the safe use facility, which some of you have been able to visit. And I really like this very much. But you can also already see what the population at that time was thinking about harm reduction. So this was 2001, and we had been working already for a long time for getting a safe injection facility. It was not that it only started in 2001. So I'll give a very short summary of what happened, just to know, but I will more focus on what I think were facilitating and limiting factors in developing this policy. And then we'll see together that I think we have to move on now, because we did a good job, and now there are new challenges we're going to discuss and see what lessons are learned. Okay? So I hope you can follow me. You can stop me anytime if there's a question. So these are the images of the early 80s that some of you, well, you're young, because now I start to be older, I feel. But at that time, in the 80s, these were the images that went around the world. This is Zurich and Platzspitz, and this was open drug scene, something we had never seen before, with people using heroin intravenously and a lot of problems. There was a rising number of people using heroin. There was the problem of the visibility. It was very visible, especially in Zurich and Bern, but also in other cities it started to rise. There was an increase in drug-related crime, and of course that was the beginning of the AIDS and hepatitis. And of course, related to the heroin, lots of overdose deaths. And what was important then, in 1988, is that 74% of the Swiss population said drugs are the second of the 10 main problems of the country. So there was really a medical problem, but there was also a political a social problem, an ethical problem, and a lot of public pressure on the public health authorities. We had to do something. And what happened then? First, you have to know there was some form of policy already since the 1970s, and that was called, well, it was like first a two-pillar system. We had only repression and prevention. There was no treatment. There was no harm reduction. Then in the end of the 70s, the therapy was added, and then we went to the well-known, well, most known model of 4 pillars, which is the repression, the regulation pillar, the prevention, the therapy, and the harm reduction. And this model it was entered in the narcotic law in 2011, which is very important because harm reduction is now part of our law. So that's very important. But you have seen there's a lot of time going between the years to get this really being part of a real policy. Well, these things I think you know. What's prevention, what's harm reduction, what's therapy, and what's repression of control. What is important to realize is that the repression control pillar takes at least 70% of all the financial means of the costs. And prevention and harm reduction are really the smallest. It's like 4 to 5% of the budget, and therapy around 20%. So it looks like a well-balanced model, if you see it, but in fact, the money is something else, and that we heard it already also this morning, and that we use the most of the money for drug policy, for regulation, repression, and control, also in Switzerland. We're supposed to talk about harm reduction. Some aspects which are very important is that needle exchange were the first harm reduction measures, and very quickly they were also in prison and in the hospital, because people said, this is your right. If we accept needle exchange programs outside, in the outside world, it should be also in inpatient or in sanitary settings. So this is something that was done right from the beginning. The drug checking programs, they took a long time to get them because there's a whole problem with the legal side of it, being able to test an illegal substance, get it and not and organize this. And harm reduction has always been also including trying to propose shelters, contact centers, job programs, etc., etc. For the therapy, what's important that it was a really a diversified treatment offer. I will go back to that later, but I think it's not only abstinence-oriented, it's not only agonist treatment, it's really, we propose everything. The objectives of this 4-pillar drug policy was to reduce the number of new users, to increase the number of people quitting addiction, to reduce health damage, reduce the social marginalization of people using drugs, and protect families, society from the negative impact of drug problems and reduce criminality. Of course, these were the objectives, and some have been attained, and not all. Because, of course, drugs remained illegal, there was a black market, there's a lot of money going on, so the last parts are, I think, not attained. The services that were provided were really a wide range with different addiction treatment and detoxification centers, and also very important, the role of primary care physicians. Primary care physicians in Switzerland can prescribe opiate agonist treatment, be it buprenorphine, methadone, or a long-acting morphine, not heroin, that's in special programs, but it's very important to provide this overall access, and this has been the case since a long time. Opiate agonist treatment is also, and detoxification is also available in prison. There have been a lot of therapeutic communities. They have been evolving. In the beginning, there were no agonist treatments. There was no psychiatric treatment. They have been accepting this, but they're slowly disappearing. There's more focus now on apartments, housing, etc., work programs. And what is important to know is that this is something that's not available everywhere. You have 26 cantons in Switzerland. There are a few cantons where you have no heroin treatment, no safe use facility, and very few needle exchange programs. So it's not something that's everywhere. It's mainly in the big cities, but access to treatment or harm reduction can be difficult if you live outside the cities. Well, very placative, this, like these were the results. I'm not going to give a lot of data, but the open drug scenes turned into a nice park and people were allowed to enter drug treatment. And I think the most important thing, what happened then, was that heroin treatment was medicalized. The whole heroin issue became like a medical problem with treatment, and it allowed people to enter treatment, and there's been a huge increase in people accessing to treatment. And also, here you see some data. There were around 2,000 people in agonist treatment in 1997, and 10 years later there were over 18,000, which is we estimate it was around 60 to 70% of the people using heroin. That was stable for a long time, is decreasing now. Heroin is not so much a problem anymore. Those who were in treatment then, many of them are still there, but they aged as I did. Around 8% are in heroin-assisted treatment, in specialized treatment centers, and as I said, 60% has been following in primary care settings. With reference to the type of medication used, it's very interesting, listening to the talk this morning, we have been for a long time proposing mostly methadone, and in fact people were given the choice to give, well, do you want methadone, do you want buprenorphine? And people in general wanted methadone. So we had almost about 90% or 80 to 90% methadone, and 8% buprenorphine, and 8% heroin. And now this has been shifting the last 10 years. Slowly there's a change from methadone to slow release morphine. But buprenorphine is not very favorite in substance in Switzerland. Overall, there was a decrease in the incidence and the prevalence of heroin use. So it's not that we offered everything that people were using more heroin. No, it's the opposite. Okay? So we are stuck with an aging population. That's also one of the reasons why there's more morphine treatment now, probably because it has less interactions with all the other medications they have. There has been a decrease in overdose death, a decrease in incidence and prevalence of HIV, hepatitis B, hepatitis C, as we've seen all over Europe. The public safety increased, and the visibility of the drug problem decreased. Drug use was less considered as a societal problem. And what's important to know is that the public voted several times on the issue of harm reduction and heroin treatment, and in general about drugs. So in 1997, there was a vote against all substances, all harm reduction, sorry, and 70% of people said, no, we want harm reduction, we want access to this. Droleg wanted to legalize drugs in 1998. That was refused also. Maybe we should do it again now. Then about the continuation of the heroin treatment programs in 1999, that was accepted 54% and entered into the law in 2011. In 2008, there was the vote, and 2011 it entered into the law. What was good about this, that these were occasions to actively communicate about drug use. So I think that was really important. We kept it on the agenda all the time. It was really an issue. We were always working with the police, with the political parties, with the patients, with people who were able to speak. So, and all professionals always worked together in preparation of these votations. And now we didn't have a votation since 15 years. And I think it's a pity. We should have something, maybe with the cannabis regulation projects, we'll have some in the future. What allowed this big change? I think it allowed it there was really a crisis. Never waste a good crisis, and I think we didn't waste it. It was also good to have a conceptual framework that gave a place for all people in the drug policy. So we were not against each other, police against people working in harm reduction. No, we were working together for a common aim. There was a huge political support. We were very happy to have Mrs. Dreyfus then as in our government, and she was a driving force behind a lot of initiatives. And also at the Swiss Federal Office of Public Health, there were key persons that allowed us to go on. There were coordinating commissions at the cantonal level and the federal level, and I think this is very important. Places where people from the field work together with the local government. People meet the police, people working in the streets, people from the communities, and they work together to elaborate the plans. Important also is that our public health insurance covers addiction treatment. And of course, there has been a lot of communication and active communication, and you really have to work on this. And what limited, of course, this, and what are maybe still limiting factors, is that there's the ideology that still remains for some people. The frequent votations had a positive side, but also a negative side, because it gives a lot of uncertainty. If people would vote against heroin treatment programs, we should close from one day to another the heroin programs. Lack of training of new professionals. All the time there's a discussion who has to pay treatment. And now there's a lack of interest, and be it from the political side and from the population over time, because now it's not an issue anymore. People are more worried about migrants, about climate change, and drug policy. Nobody's interested anymore. Our policy has changed a bit over time. The 4 pillars were adapted to all substances, which is an interesting thing, as we've seen in the field of addiction medicine. First, we had people who were taking care of alcohol, others of tobacco, and others of illegal drugs. Now we all work together and offer the same type of treatment. This has helped to make let's say the people work in the same way. So what are new challenges? Is first to maintain drug policies on the political agenda. Okay, so second thing is the regulation of drugs. Now we are talking about the regulation of the cannabis market, but not about other drugs, not yet. So there are currently pilot projects on cannabis regulation in several Swiss cities, and we hope that there might be a votation to have a regulated cannabis markets in a few years. And this has been proposed since 1999 by the Swiss Federal Commission on Drug-Related Affairs, but it has never been followed. And of course, we had only the heroin problem, plus of course the alcohol and the tobacco, but now we have different issues. We have no more pure heroin users. People are using different substances. In young people, we see a lot of mixtures of alcohol with medications that are ordered online. We have different subgroups with specific risk behavior, and we have since 2 years the crack market in different cities. Those who have been to Kenneuf, you might have seen it. This is our safe use facility in this summer. In fact, we have now ready-made crack on the market, so which is quite cheap, very accessible, and very, aggressive marketing for this. And there's an increase in crack use just behind the Kenef and a little bit at other sites also. The profile of these people are, in general, elderly people that we knew from our other programs, but in fact, it's those who were in social exclusion, not having a job, and we don't know what to do with them. The numbers are not very high in absolute data, but it's very visible and it's increasing. So it's really very worrisome. Of course, we have to think about a different approach. These are not people using intravenously, they're smoking. They have less immediate physical risks, there's no overdose, but at long term, people have this problem of lack of sleep, of lack of eating, a lack of care for themselves. They lose weight, they get paranoid, and of course we have no agonist treatment available. This is really our new challenge, and we don't know very much what to do with it. And I think there's also a need to innovate our 4-pillar models. The causes of these changes in the market is, I think, really, there are several reasons, and this is a report made by the GREA, the Groupement Roman des Études sur les Addictions. First is the social exclusion of vulnerable persons, as maybe worse since the COVID epidemic. There's a high availability and of good quality of substances. And there's a transformation of the market and the way substances are used that are problematic and mental health issues. So what we should think about is how to adapt our harm reduction places. Maybe we should, like we're going to have now probably in Geneva, is a separate place for people using crack, because it was impossible to handle the crack users within the safe use facility. We have to act upon the precarization, including those in need, and especially think about the housing first and access to paid jobs. We have to pacify public spaces. We have to do more outreach and maybe have shelters for 20 hours a day. And we have to facilitate access to minors for everybody, no more complicated administrative measures, just have less administration and be able to care for them quickly. And also, I think there's a need to improve interprofessional and regional collaboration and monitoring. What we see is that one city takes a measure, and then the market quickly moves to the city next to it. So we have to work together. Lessons learned is, I think overall, that our 4 pillars drug policy was really a coherent and effective policy with an enormous public health impact. It was accepted by the public and almost all political parties. It was applicable in and out of prison. But now the reality is different, and we should think about our 4 pillars. We have to address these new open drug scenes, the new substances, and especially think about the regulation of the market. We also have the free market, which has a lot of public health problems. If you think about tobacco and alcohol, prohibition has the other issues. So we have to move on and to rethink our approaches, notably about social integration, housing, and the market regulation. Thank you very much for your attention.
So thank you, Barbara, for your important presentation. I remember to the audience that they can submit their question through the app, and that all the questions will be held at the end of the session after the 3 presentations together. So please, yes, Barbara, have a seat. So next speaker comes again from Switzerland, but now from Zurich, Dr. Lina Ijazi. She's a consultant HIV and sexual reproductive health specialist at the ARUD Zurich. I read that you are also a dermatologist, and that's great. I would love to have a dermatologist also in my center. And your presentation is about integrated OAT care, the example of integrating female health. So please, Lina, the floor is yours.
Alberto, thank you very much for that introduction. Thank you all for being here, and I thank INCHU for inviting me to speak today. My remit was to talk about integrated ORT care and looking at integrating female health into the clinic. I have no conflicts of interest, obviously, and I'd like to thank all the people who've allowed their data to be used in any of the studies that I have used for the presentation today. So what am I going to cover today? This is really interesting. I thought I'd start off with what is integrated care? I mean, in medical school, it's what I studied. It's normal, but I'm like, what is the history behind it? Are there examples of it here in Switzerland? Then look at why women. I mean, this is a theme for this year's conference, but why specifically, from my point of view at least? And then description of our version of integrated healthcare provision in Aarhus and Zurich. So what is integrated care? Actually, the history is the integration of mental and physical health under one service provider. Traditionally, in the olden ages, the physician looked after your broken bones, and the priest of whichever religion looked after the soul, and so your mental health. And this idea of integration of physical and psychological health started really with Dr. Damerel, who's a German psychiatrist, who championed the idea in the 1800s and actually got it funded, and this is how he practiced in his lunatic asylum at the time, as it was called. And then this question sort of kept resurfacing and was always discussed and never really quite established until 1977, when George Engel proposed this biopsychosocial model of care, which emphasized the interaction between mental, physical, and social factors in the outcome of healthcare of an individual. And that's really when this whole idea gained traction and started becoming mainstream. Then the question is, why integrated care? Surely we have hospitals. Hospitals have everything under one roof. That's integrated enough, isn't it? What makes integrated care really important is not just that they're co-located, but the transfer of information and putting the patient or the person in the middle of this whole process. So information is shared among team members, and we get a comprehensive treatment plan, not only for the now, the acute sitting, the crisis, the whatever is happening at the moment, but also how are we going to transition this person back to their home environment in whichever way, and what support do they need to achieve that, and what follow-up and by whom. And this was the American Psychological Association's definition, and there are many on the internet, and this was just one that I thought made really good sense for me. And the WHO obviously has enough evidence for it and supports countries in moving their health systems towards this universal health coverage that has equitable, quality healthcare services, integrated, safe, and people-centered. And that's really, really important. So why do it? I mean, the WHO can say what it likes, but why should we do it? And that's because it has been proven. The data is scattered. It's a lot of modeling and a lot of sort of various countries doing little things to show it. But overall, we can see that's improved healthcare outcomes with fewer unnecessary hospitalizations, improved access to services, and less cost. At the bottom line is the dollar sign. And what about for us in our specialty, for our ORT treatment centers? There was a number of studies, mainly from America, that showed that people who had this kind of integrated care had reduced or discontinued substance use with improved psychiatric symptoms and functioning, decreased hospitalization, reduced medical interactions through drug-drug interactions, because we transferred the information. By the way, he stopped this or she started that. Pay attention to what's on your drug list. And increasing housing stability, fewer arrests, culminating effectively in what we want for everybody, which is improved quality of life. And I think this is really important data. Who is part of this team? I mean, what does that mean? Really, anybody and everybody can be part of the team. Looking at the traditional sort of medical models of care, you'll have the doctors, the nurses, the physio-occupational therapists. This is all quite standard. Social workers, that's also quite standard. But then we need to think a little bit further. In the community, who's there other than the GP? Are there non-governmental organizations? Are there other support agencies, community movements that we can sort of bring in to support the individual? What about their family, their friends, their peer workers from within or within the clinic or within the community? And also in the background, we need to look at public health for the country and engage with them to support us in providing the care we need. And we must never ever forget the people who pay for this, whether it's the insurance companies, the governments, third party, these big billionaires who want to give money for various programs. We need to engage with them and keep our agenda on their agenda so the money keeps flowing so we can provide what we need to provide. And then the question is, what examples do we have from here in Switzerland? Do we have integrated care? Because we all know, we all work in Switzerland. It's cantonal, it's Krankenkasse, it's the insurance. And therefore, what have we done here? What do we know? And basically, the data that I found was from Severin Filitas, who works for public health, and she did a survey between 2015 and 2016, looking at what integration is available across all cantons. And then she did an analysis and then a secondary analysis of that data. And what she saw is over the years, there's been increasing integration of care within the canton especially. We all know that when someone is not from this canton trying to provide certain care, it means you have to write to the insurance or write for someone to get special permission for it to be funded sometimes. And this integration where people were working more in groups, more in networks, started off in the 1990s, mainly physicians working together. And then after 2008, looking at transition of care from inpatient to outpatient settings. Apparently, it initially started in the German-speaking regions, but from 2012 is actually much more widely spread throughout Switzerland. And interestingly, apparently there was a sort of German, non-German divide in how things were done, where the German-speaking regions had more physicians' networks and healthcare center initiative, while the other regions were more initiatives targeting specific groups, drug management, and coordination of care. But that might also reflect the learning that has happened over the years. And so, they learned, they moved on and did the best they could for their regions and with the best data. She also identified barriers to integration of care, because if it works and it works internationally, why doesn't everyone do it immediately? There's a professional level. It's like, if I integrate my care, if I give something else to someone else, what about the pay? I mean, it's all insurance-based. That's something we need to be aware of. And she identified also system-level barriers, which includes lack of sort of political will and support for the physicians and professionals providing this care. And what about in OAT? Here, I have to say, there is no central database. There is no survey. And so I did a combination of Google search for every canton, looking at what they provided. And Dr. Brugman helped me with a few sort of bigger cities saying, try this, try that, have a look at what they provide. As far as I could see, and my apologies if this is not 100% accurate for all cantons, but basically, as far as I could tell, all OAT providers have integrated psychiatric and psychological care. So you have psychiatrists and psychologists working together, which is great. Most of the major healthcare providers, again in the biggest cities, have some level of integration of mental and physical health services. What this looks like depends very much on the historical context of what is available, who are the people, what are the relationships that are already established, and they built on that, which is, of course, the way health systems sort of organically grow. Most of them have some sort of co-location of OAT-focused and internal medical services. Some people have under the same area or the same management an inpatient care facility. Some provide gynecological services on the same management structure but not the same building. Some people have specialists coming in to provide services, for example, infectious diseases to treat and manage people with hepatitis C or HIV, or vascular surgeons coming in to look at wound management on a regular basis, once a week, once a month, depending on what is needed for that particular service. And then I thought, well, why women? Other than it interests me specifically. Why women? I mean, women and men are different. We have different physiology, we have different experience of life. What we know is one of the biggest differences, not the only difference, one of the bigger physiological differences between men and women are sex hormones. We know also that opioids activate the mu receptors in the brain, and that's what is part of the addiction process, but it also activates the mu receptors in the hypothalamus, and that has a direct effect on our hormone status. We know, and we see it very often, that we do our regular bloods and thyroid, and we see an increased thyroid stimulating hormone. You do a T4, it's normal, and we just say, well, that's due to the opioids, and it is. But this has also been shown to affect our sex hormones in the form of we lose our LH pulse, which means the women can then have issues with their periods, menstruation. A lot of our women, not everybody, has amenorrhea or this irregular bleeding, and then they're not sure. Can they have kids? Do they need contraception? And do they want kids? What happens if they do get pregnant? And then a lot of women will say to me, but I don't need contraception. I don't get periods. Well, that's not true. And we know that some women come in with unplanned pregnancy because they got pregnant before the next period was due. Even for women who do want contraception, there is an issue with some of the contraceptive methods we have available. It's not paid for by the Krankenkasse, by the insurance in general, and so they have to fund it themselves. The second is due to the various other lifestyle issues, there might be limitations on what may be available for that particular person at that particular time. If a woman is pregnant and she has an unplanned pregnancy, it's then finding out in time within the first 12 weeks that enables her to have a termination of pregnancy, should she choose that. Or if she decides she wants to complete the pregnancy and have the child, then there are worries. Should I stop my OAT in pregnancy? Please don't. Should I reduce? Not without a physician telling you to and supervising, because it is extra stress. What about the child? Will they be okay? Will someone try and take the baby away from me? That's happened to me in the past. And all these feelings and thoughts and worries come into play. And then the other thing, and menopause, I'm of that age now, it becomes really important, is there is really clear evidence. A lot of our ladies who are at that age have the increasing vasomotor and other effects of menopause. They believe there's nothing to be done and suffer. And a lot of them suffer under a lot of symptoms. And actually, there are things that can be done. Restricted, yes, but there are things that can be done. And after the menopause, the women who take OAT are at higher risk of things like osteoporosis and strokes. And that's something as physicians who look after this group of women, we should be aware of. We know there's an increased risk of sexually transmitted infections. We know that there's an increase of domestic and partner violence. And I particularly like this cartoon because it just shows you that although women more often are the victim of this violence or the sufferer, but there is a family involved. Sometimes the man is the victim, and there is sometimes children in that whole dynamic that we need to be aware of. And if a woman sort of says, okay, I'm going to go to clinic, I'm going to try and do this right, for me, she has another experience of turning up to clinic. I mean, you know, this other responsibilities cartoon, we've seen it probably on social media talking about the glass ceiling in jobs, but it's the same for attending appointments. She has to drop her kid off, the kid comes back at lunch, she has to be there, she has to cook, she has to pick up her own medication, sort out all the other normal activities of daily living. And where does she put her clinic appointment? In the middle. And what about the shame of having to tell someone, yes, I'm on morphine, I'm on methadone, I'm on whatever, and what does that mean? And even if she does attend a clinic which is non-discriminatory, she may feel discriminated. You know, what are people around her saying? Oh, people see me in the waiting area and they know. It's like, no, they don't. Oh, but they're convinced. Other people know. And that means the women then sort of stay at home and don't bother engaging with the care that they need. And it's our job to try and break down these barriers and to improve the care for all of these women. Obviously, till now, I'm talking mainly about cis women, okay? Women who are born female, identifying as women, and carry on like that. But there is a small group of people in this population, smaller, I should say, that are not a big part of my service, but maybe a big part of other services. And these are the gender diverse identity community. Here, the healthcare professionals need an added layer of understanding and medical knowledge and experience to deal with all the different physical, mental health, drug-related issue needs for this population. Anybody with a cervix still needs regular pap smears, and that may be very difficult to do in women, in people with smears, with cervices who maybe had violence in the past. It's a part of their body they don't want to talk about, and it's really difficult to navigate and may take more than one appointment to actually achieve what we need. Fertility, pregnancy, and contraception are still issues that are very important for this group of population, and we know that they're at increased risk of STIs. I'm just saying that anyone who falls into this category, please pay more attention, be more aware, ask for help from relevant specialists when you need to. So what is needed? I've done this in pink to wake you guys up, but basically we need a non-discriminatory, safe, child-friendly, high-quality, integrated service for people of all stages of life, and here I specifically talk about women. Okay, and this includes the sexual and reproductive health needs in some form. So what do we provide? Basically, we provide, and I've specifically called this sexual and reproductive health service and not a gynecological service because it's not the full range. We provide contraception, and in Arud, we have taken the decision for many years now to provide Depo contraception for free, Depo-Provera or Ciana, for free to these women to help. We talk about vaccinations, especially HPV vaccination, STI screening and management, PrEP and PEP as necessary for these women. Pap smears every 3 years. I don't do them yearly, and I don't do them necessarily at the first visit unless the lady is very happy to have one. Pregnancy testing and support, and I say support very generally because I'm not a gynecologist. She still needs to attend a gynecology antenatal service and go through that support, but I'm there to calm her and help her navigate the system if she needs it. Sometimes she doesn't. Menopause, that's my little baby. Menopause advice, diagnosis, and management. And just because HRT is higher risk doesn't mean that it absolutely cannot be given ever. And there are other things that can be used. And this is really important. We don't close the door here. And I link with our gynecology service within an OT service. And I specifically send certain proportion of my ladies there with an appointment, say, you're going there specifically to see this gynecology for this specific reason. And they understand about OT, it's okay. And that really settles them down with their anxiety. We have a peer support group that will help us. They're here in the main exhibition area if you want to go visit. And there's more about my clinic, just a little bit of a poster at poster 15. So this is what we provide at Arud, and we really try as best we can to provide everything we possibly can under one roof. It's integrated, it's a comprehensive addiction service with the medical things, sort of general medicine, infectious diseases, STI clinic, sexual reproductive health. We have wound clinic for those that have wounds and abscesses. We have social workers with a walk-in facility. We have on-call internal medicine and psychiatric services, as well as the usual psychological support that we all have. We have peers who are very active and engage with our communities. And obviously, and centrally, we have an OAT service with a needle exchange program. And we try and provide as much research as we can to inform what we do, what our patients or our clients need, and also the general population. And I thank you very much for your attention.
Thank you very much, Lina.
Thank you.
So now I'm very pleased to introduce Louise Petzenstalder, who is a psychiatrist responsible for the community treatment team at the addiction division of the University Hospital of Geneva. Thanks, Louise.
Thank you very much for inviting me. So today I'm going to present something different. I'm going to talk about psychedelics in addiction therapy. First of all, I would like to give an overview of effects of psychedelics and how these might be used in addiction therapy. Afterwards, some current evidence in the field, and afterwards I would like to present our program, which we are running at the moment in our department for psychedelics. In our addiction department, we've got a compassionate use program for psychedelics. So what are psychedelics? There are different types. We have classical psychedelics, which are partial agonists of the 5-HT2A receptors, under which we have LSD, psilocybin, DMT, mescaline. There are entactogens and empathogens, which are serotonin receptor agonists, where you have MDMA, etc. We also have dissociative anesthetics, MDMA antagonists like ketamine and PCP, angel dust, and there are some atypical hallucinogenics. I only mentioned one, such as salvia divinorum. What do psychedelics do? So psychedelics make people experience an altered state of consciousness, which is for all types of psychedelics, which you have various dimensions. So first of all, you have oceanic boundlessness, which is an important dimension, which is can be described as a positively experienced loss of ego or loss of self. And it's normally linked to a heightened, elevated mood, blissful state. You have the impression of being one with the universe, so this is typically described by patients by a kind of mystical experience. We also have a visionary restrictualization, which explains typical changes in perception, like hallucinations, illusions. We have increased imagination, a higher, better capacity to recall memories. And there's also the anxious ego dissolution, which, contrary to oceanic boundlessness, is the negatively experienced loss of self, and you get the impression you don't have control over your body and over your thinking, which is something which is very, patients are very anxious, have a lot of anxiety and fear when this happens. It has to be said that in therapeutic settings with moderate doses of psychedelics, this is extremely rare, and it typically happens in non-therapeutic settings with very high doses of psychedelics, and it's commonly called a bad trip. Today I'm going to talk about LSD and psilocybin because it's the two substances which have been researched for addiction therapy, and also in general a lot of, some research has been done specifically on these substances for mental health disorders. So LSD, we have an onset effect of about 30 to 60 minutes with a peak at 1.5 hours, and then the effect gradually decreases over the day up to about 5 hours, and the effect can still be felt for about 12 hours. Patients perceive effects from about 20 micrograms, and therapeutic doses are between 100 and 300 micrograms, although I would say more like 100 and 200 micrograms. 300 is a very high dose. Psilocybin, on the other hand, you have an effect after 10 to 40 minutes, and the duration of the effect is short. It's about 2 to 6 hours, which also makes it an interesting substance to use in outpatient setting. And there you have a psychedelic effect from about 5 milligrams, and therapeutic doses range from about 15 to 35 milligrams. What are the effects of psychedelics? So I have mentioned a few here. The main thing to remember from this slide is that they increase neuroplasticity, which is important, and which can improve learning, behavioral learning for patients, for example. Here you have another slide. I'm not going to go into all the detail, but there are alterations in the integrative networks which are experienced by patients. You can see there are some brain areas which have increased and decreased connectivity in this network. And what is important is that you can see an increased connectivity between sensory cortices and the rest of the brain, which is responsible for this increased sensory processing, and when patients describe these changes in perception. And on the other hand, you have a decreased connectivity between the association cortex and the rest of the brain, meaning there's decreased integrative processing. So you don't have this top-down information from the cortex, which is going to influence your experience. And this disbalance is typically what is hypothesized to lead to the psychedelic experience with these drugs. You might have already seen this slide. This image is quite often shown because it's very interesting. There is also an increased connectivity in the brain. So when patients are under psilocybin, there are all the different areas of the brain which are communicating. There are microcircuits which normally don't interact. And this is very interesting because this explains things like senses of synesthesia, where patients can hear colors or see sounds, for example. This comes from these connections of areas which normally don't connect. On a psychological level, you have increased cognitive and psychological flexibility. Patients have this experience of psychological insight and suddenly understanding things which they didn't understand before. There's a heightened emotional acceptance, and patients describe peak experiences in this mystical type states. Now, how can we use this in addiction therapy? I think it's important to say when patients suffer from an addiction, what is interesting is there are these repetitive behaviors. Patients with the same triggers, they will also always fall into the same behavior, repeat, despite negative consequences. Triggers will always lead to the same behavior. And what we would like when patients recover, in order to recover from an addiction, is to have new choices, to be able to react differently to certain triggers and imagine other possible selves, because what we do know, patients with addictive disorders often start their addictive behavior at a fairly young age, and it's often difficult. They have integrated this identity of having an addiction as part of themselves. It's very difficult for them to imagine other futures and other things they could be doing. And for this, the neuroreorganization, neuroplasticity, which patients have during the psychedelic session can really help. Also, as I said, there's a heightened imagination. Patients have this feeling of oneness with the world, which gives them all kinds of ideas and increases what can I be doing with my life, what can I be doing in the future. And it's very important that this is worked on in psychotherapy, because all the session you live through a certain number of experiences, but it's very important to integrate these experiences into a psychotherapeutic process in order to be able to come up with a new possible self and a new future. What evidence do we have in the field of addiction treatment? So there were quite a few studies done in the 60s using LSD for alcohol dependency. There was a pooled analysis done where they chose 6 randomized control styles where they took the patients together from this recently. And they came up with 536 patients who had a single dose of LSD. And they found that alcohol consumption significantly reduced after 3 and 6 months. Today we have some research as well. An important study is this one from Bogenschutz, which is a proof of concept study, the first recently in the field. So there they had 10 voluntary patients who suffered from an alcohol use disorder, and they were given 1 or 2 sessions of psilocybin, and this was added on to motivation enhancement therapy. And there they saw a significant reduction in drinking days and heavy drinking days. And after they had this evidence, they went on to do a larger study, which was a randomized controlled trial where they had about 90 patients. And here again, they note they had 2 sessions of psilocybin with this motivated enhancement therapy, and they found a significant reduction in heavy drinking days, and also drinks per day. And here you can see the study went on for 36 weeks, and the effects have had a prolonged effect. And it's also interesting to see that the reduction of alcohol consumption was very, very immediate after the psilocybin administration. Here just a bit of info, just to see, these are the studies which have been done on substance use disorder and psilocybin. So we have some with alcohol and one with tobacco. Not too many for now, but when you see, if you look into clinical trials and you want to see all that's being done at the moment, you just see there's a large number of studies going on at the moment in different countries, a lot on alcohol use disorder, but we're also starting to study psychedelic treatment for patients with opioid use disorders, cocaine use disorder, methamphetamine. So there's really growing interest in these substances in research all over the world. Now I would like to give a few informations about our program. So we have this compassionate use program, which means that patients who are potentially seriously ill and can be treated under the by substances which are currently not licensed in Switzerland if it's an emergency intervention, or as in our case, an intervention of last resort. In order to be able to do this, you need to have significant scientific results available, which so that there is a therapeutic effect can be expected, which is the case with psychedelics. And in this case, you can ask for a limited medical application from the Federal Office of Public Health. Patient obviously has to give informed consent. Then, when patients, we have a lot of demands at the moment, obviously. Patients are either addressed to us by their therapists, or they contact us by themselves. So in the first session, we will screen the patients to make sure that they fulfill the inclusion criteria, which is needed in order to ask for this limited medical application. Patients have to be adult. They have to suffer from a disorder for which we already have some evidence for psychedelics, which is studies have been done on depressive disorders, anxiety disorders, also obsessive compulsive disorder, and addictive disorder. They need to have a severe clinical presentation and significant impairment of functioning and quality of life. In order to be a treatment of last intent, you have to have had several unsuccessful treatments, typically pharmaceutically and psychotherapy. Patients need to be in psychotherapy follow-up treatment during the time of the session. As I said before, it's very important to integrate what happens in the session into your psychotherapy in order to use this material in a constructive way. And patients need to be residing in Switzerland. I mentioned that because as we're in Geneva, there are a lot of patients who live in France, and if you're not resident in Switzerland, you can't take part. That's the way it is. If they fulfill all the inclusion criteria, you can ask for this exceptional authorization. And then patients, once we get it, they will be invited to preparatory session where they will get to know the team, they can see the treatment rooms, they are informed of how this session is going to be, some general information. And very important, we try and establish session objectives for the patients to see what are they expecting from this session. Obviously, most people will say, I want my symptoms to be reduced, but we try and find out a bit more and work on this with the patient before the therapy. We determine the dosage, and before this, we obviously had to determine the substance already, so they can choose between LSD and psilocybin. Then the patient comes for the session, which takes part in an outpatient center. It starts in the morning at 9 o'clock. Patients then spend all the day at the clinic. They're generally in a bed or on a mattress and listen to music, which they can choose themselves. They often wear an eye mask. The idea is to increase the introspection during the session. We don't have a lot of specific interaction during the session except for asking the patient if they're feeling okay. We do measure the effects and side effects after a certain amount of time. Then the next day, the patient will come to an integration session. In this session, the patient will narrate what they experienced, and this will be recorded. The idea of having the recording is to give this to the patient after the session, and also to give it to the psychotherapist so that both can listen to this again. We try and link the narration of the session with the therapeutic goals, and then the patient will carry on with his psychotherapy. We then, after 1 month, we have an amplification session, which is mainly to see the patient again, because often they're treated by therapists who are not working in our department. What's important to find out is to see how the patient could actually integrate the session and the ideas he had and what he tried to put into place after the session in his everyday life, and how he's advanced in psychotherapy and what's happened. And at that moment, normally we assess if the patient needs another session. With this exception authorization, it's valid for 1 year, and patients can have up to 3 sessions. It's always possible to ask for prolongation if it's estimated necessary. In general, we wait for at least 4 weeks between the sessions, but it's more common to have about 2 or 3 months, because it's also often described by the patient they need time to work on all the information which evolved during the session. And then at the end we have a follow-up, and we evaluate at the end how the patient is doing. The products we're using is LSD, either 100 or 200 micrograms, and we have psilocybin in 5 milligram capsules. We normally start with 25 milligrams, and 25 milligrams is more or less equivalent to 100 micrograms of LSD from the effects, and we then can go up to 40 milligrams. We decide this each session if we're going to increase the dose. Here you have some pictures from what it looks like. As you see, it's very, very neutral. They have either bed or mattress, depending on patients' preferences. We can measure blood pressure if needed, but we normally just measure at the beginning of the session or the end. There's always a nurse which is present in the room, but the patients are behind these paravents, so they don't feel observed constantly, which is not very nice. Obviously, also a doctor is always present in the building and can come at any time necessary. So we launched the program in June 2020. The numbers I've here slightly increased since I last counted, but at least slightly more than 166 authorizations. We've treated more than 100 patients, slightly more with psilocybin than with LSD. And yeah, there've been quite a few more single sessions, and some patients already had 2 sessions and some 3. The diagnosis for the patients we're treating at the moment have been recurrent depressive disorders, anxiety disorders, addictive disorders, and OCD. As you see here, we have less patients treated with addictive disorders. This is due to the fact that at the beginning, when we started the program, we mainly treated patients with depression. And now we are treating more and more patients with addictive disorders, so these numbers will surely go up. Majority of patients with alcohol use disorder, but also other substances. So far, first impression from the program, we have, was important to say, I think, have not had any adverse reactions during treatment. The patient, obviously, some patient will experience some anxiety during the session, but this is totally normal and something which we can also be very helpful because it means the patient actually went through a difficult moment and managed it, and perhaps has managed to work on some difficult memory or something like that. Ideally, when we're talking about patients with addiction, ideally they should be sober during the treatment. And if this is difficult in outpatient setting, we can also do the treatment in inpatients, in our inpatient unit at the hospital. What's mainly what we, on the other hand, what we really need to avoid are withdrawal symptoms, so patients will be taking benzodiazepine if needed, also on the treatment day. This is not a problem. Patient satisfaction is very high. And we have got a few results already. We now have to start working on the large amount of data which we've collected. This is still a smaller sample of 27 patients from which I had before and after at the end of the treatment. You can see this one was done for about half of the patient had LSD and the other half had psilocybin. And as these are the treatment data from the first patients, mainly patients had a depressive disorder, but some also obviously had mixed diagnosis with anxiety disorders and others. And what we found so far, we have the Beck's Depression Inventory and the Hamilton Score, which measure depressive symptoms in our patients, and then we have the STAI Trait and State Score, which measures anxious symptoms in patients, anxious traits in their personality. And we found a significant reduction of both depressive and anxious symptoms in all these patients. And what's also I find is extremely interesting is that not only the anxiety, the STAI State Score, which measures the actual anxiety in the moment, has significantly reduced, but also the STAI Trait Score, which is actually something which is meant to be stable over time because it reflects what kind of person you are, if you're more anxiously inclined. And I think it's very interesting that the psychedelic treatment seems to have changed that and actually had some more impact on how you react in the world and how you see things. So I think that's very interesting. So perhaps just a final summary. So psychedelic treatment is associated with very high expectations. I think this is important because patients I've heard about this, it's everywhere on the media at the moment, so patients come in, expect a lot from it. At the same time, it's something which is new and there's a lot of, some research is being done at the moment, so we hope this is going to be helpful. We do have some promising studies, but it's still very limited data because as you saw, the patient groups in the studies are very small. It appears to have few side effects when it's done in therapeutic setting, but again, as they had very small patient numbers in the studies, you can be sure that the patients were very carefully selected, they were well prepared for this treatment. A big problem in the studies is the blinding, because if you want to find out if a treatment is effective, ideally you want to do a randomized controlled trial with a placebo, and the problem is that it's practically impossible to blind patients to the psychedelic effect. There have been some trials where they try and give patients a very low dose of psychedelics, but or some other substance which makes them a bit drowsy and you get blurred vision. I don't have the numbers exactly, but one study found that I think 95% of patients and researchers knew if the patient had received the psychedelic or not. So this is difficult. But so far we need more research on it, but it is potentially a breakthrough treatment. So we're excited about it.
So thank you very much for this presentation, these three presentations, very interesting. So you all gave a lot of ideas of discussion. So first, we can open the discussion to the audience if you have any question from the audience. We didn't receive any question to the tablet, so I don't know if someone submitted. Someone has any question? Yes, please.
Todd Korthus, Portland, Oregon, in the U.S. Question for Dr. Pintstadler. Actually, two questions. First of all, did I understand correctly that there's a single integration session that's required after each session? And is there an option for additional psychotherapy in between sessions? And secondly, is there crossover allowed between LSD and psilocybin? So if somebody starts with one, they can switch to the other, and what does that look like?
Thank you for the question. So for the patients who are treated in the program, they have one integration session after the treatment with us, so with the staff from our clinic. But all patients to be ordered to be in the program have to be currently in psychotherapy. So they will carry on working on this session in psychotherapy, either with their private psychiatrist or some of the patients, obviously also with us, which one session would definitely not be enough. So some patients have had long-term psychotherapy, and they will increase the intensity of the therapy around the session. And to the second question, so when you ask for a limited medical application, you have to decide with the patient which substance you would like to use. There's no studies which compare both substances, so we don't really know which one works better. We have the impression that they both work very similarly. It's just a question of length of time patient has to stay, and also in price. Psilocybin at the moment in Switzerland is a lot more expensive than LSD because it's been around longer mainly. If patients want to switch because they had one substance and they find that the effect perhaps was not good and they want to try the other one, we have to ask for another authorization, but it is possible. We've done it.
Thanks. Fantastic. 3 presentations. Niklas Luhmann from WHO. But a question as well to the last one. I was wondering as well a little bit how you choose between the 2 substances if it's a patient choice or how you. I wanted to as well just check if I understood correctly. The dosages that you use, would you say that this is on the microdosing side, or compared to what is taken recreationally with a lot of psychoactive effects maybe? And then last but not least, I was wondering if you're talking a lot with other colleagues who do use those substances, end of life, pain, and I mean there's a lot going on in the States and Europe in that field. Thanks.
Thank you for the question. So we're not working with microdosing at the moment so far. We don't have enough research which has given us any evidence for it, but it's interesting. We have to see what happens. The doses we use is a proper psychedelic session, so you have all the effects. LSD, we start at 100 micrograms and we go up to 200. I think 300 is really a lot. And psilocybin, we used to start with 15 milligrams, but the patients didn't have much effect, so we're now doing 25 to start, and then we go up depending on the patient. How we choose between the substances, really discussing with the patients. A lot of patients have read a lot about it and have their own ideas what they would prefer. We're really open for that. And yes, I mean, we are in contact with other colleagues, a lot in Switzerland, obviously, who are also, we're going to participate in a study for alcohol use disorder, and we're currently trying to get a study through the ethics committee. It's not that easy for opioid use disorder. And mainly we're talking to other psychiatrists who are treating patients with depression. I know there's a lot also for end of life, but we haven't got so much contact with them.
Hi, just a question for Louise as well. Is this program only available in the University Hospital in Geneva? Is it available anywhere else in the country?
So it's available in our hospital. Other colleagues are doing as well. If you are a private psychiatrist or doctor, you can ask for this limited medical application for your patient. And then if you get it, you can order the substance in a certain laboratory and use it. So far, there are some private people who do it, but it's true that it requires a lot of organization. The patient has to be supervised for 8 hours. It's quite difficult. I know other centers in Basel and Zurich doing it too, but mainly for studies.
Yeah, maybe a comment, because we were in a session on successes in harm reduction implementation. And to avoid any misunderstanding, of course, the psychedelic assisted therapy is not a form of harm reduction. It's really an innovative form of treatment, but it's very exciting. But I have to say that I'm a bit skeptical because it gives so much hope for patients. They want this quick fix, and I'm very afraid that there might be disappointment afterwards because the social misery is still there, the discrimination is still there, the social exclusion is there. So I would like to ask you the question, what do you think of that? Because how can we accompany this with real harm reduction also? Because you will see, if you work in this field, it's like a hype, Oh, we have a new thing. Oh, fantastic. Everybody wants to try it. And we think, this will cure, which is probably not the case. And I would like to have your comment on it.
Thank you for that remark. I think it's very important to keep that in mind. Patients do come with a high expectations into the treatment, and it's really important. I said we had one screening session, but often we see patients really more than once because it's really something which has to be worked on. What do they actually expect from the treatment? And as you said, it's not a quick fix. It's something which has to then be worked on over a longer period in psychotherapy. So far, it's true that the patients we've been treating have contacted us who come from a more private sector. So we want to now do this in patients with opioid use disorder, so that we will have patients who are in socially more difficult situations. And I think, as in all treatments, if you don't include the social problems and everything which comes with it, the patient can't get better. And I think, as I said, I'm co-responsible for this program, but my main area of work is actually in community treatment and assertive outreach, and it's something which I find extremely important, and it needs to be considered. You can't just look at one part of the patient. It's not going to work.
Hello, thank you very much for your presentation. It's, as Dr. Broer said, very exciting. I have some patients. I'm a GP, an addiction medicine doctor, and I have some patients that were willing to get into this therapy. How do you define actually the lack of response to OAT treatments? So how do you define this criteria, which I see is very important for the patient to be eventually included?
The lack of response so far, so for depression, for example, it would be the lack of symptom improvement with an antidepressant, for example. For a patient with OAT, for me, it would be that they still polyconsumption, regular relapse, for example. And to be fair, until now, most of the patients with addiction were treated under the angle of suffering from coexisting depressions of anxiety disorder. Mainly that.
I appreciate Dr. Broer's comments about harm reduction. In the US, as this hype has taken hold, it's spilled over into the unsupervised use. We have dramatic increases in unsupervised use. What's the conversation in Switzerland harm reduction community about reducing the harms of psychedelic use outside of a therapeutic situation? We know they're small, but they're not zero.
Yeah, maybe I can add also, we have been talking about it already in the Federal Commission, that it is important that we look more at negative side effects like sexual abuse by people, and also you have to know the psychedelic assisted therapy is not always done in a formal setting, also in an informal setting by people who say they are specialists, but there's no control. And of course, people who are in a different psychological state, you know, they are vulnerable. And especially if you know that people with PTSD and sexual abuse in the past can also, you know, look for this, you know, say, I need this, and then put themselves in an unsafe situation. So I think there's a sensibilization ongoing about, you know, this. But I think it's important to better know what's ongoing, and I think there's a lack of data. We know that people go to you know, other settings because it's less expensive very often than the official things where people have to pay for their treatment only if it's out of the research. So it's a very important question, and I think we need to know more what people think about them themselves in the harm reduction field.
No, I agree. There is a lot. It's very dangerous, and unfortunately, it's not even necessarily less expensive, but patients are even getting exploited and being asked to pay on private money for these sessions because, in theory, most of the treatment can be covered by their health insurance. So this is also, there's a lot of abuse. And one point that we're trying to do, there are several psychedelic societies. We're trying to work on official guidelines where we try and make sure that this is said officially, that typically some behaviors are not acceptable in the treatment setting.
Does anyone have any question? So I have a question for Lina. I like very much your slide about the barriers that limit access to care for women. In my experience, we had in our center, for example, a situation where we have a group of young ladies, high consumers, that have a really hard time to come to treat hepatitis C. So not just all about gynecologist or reproductive health. And actually, they remained the last with hepatitis C in our group, and they were sustaining the epidemics. And it was difficult. And to me, we solved the problem by hiring a female ID doctor that helped it very much, and also to create a group of women, so nurses, social worker, that really developed a program on it. I don't know if it's something that you also observed in your setting.
Luckily in Aarhus, we don't have that problem at the moment. Our problem tends to be more that the person who's hepatitis C positive for some reason isn't able, and they're not young people, they're sort of older, but maybe more sort of off medical care consumption. And basically the strategies that need to be used is to somehow either link it to something they do regularly, because now our treatments are 1 or 3 tablets once a day. So a group of our patients have been treated with they come in daily, they take their medications, we give them their medications there and then, they take it, that's done. Or creating a safe space, which is what you've done for these women. And of course, depending on the service you have and the group of people you have, the solutions will be different. And I think this is where it's really, really important to take the person's point of view, and surveys of the clients, patients, whatever you want to call your users, service users, into account is really important. And just say, what is it you need? How can I make it better for you? obviously taking into account the fact that we have our own limitations from a point of view, like, we're not going to work at midnight, and there are financial restraints as to what we can and cannot do. But it has to be a person per person or group by group. I mean, we have done a lot of work in relinking hepatitis C people to care by intensifying, trying to call them, trying to engage with them. We have peer workers who are really important in also trying to re-engage and engage and then re-engage with this population group. I think we all need to use whatever tools we have in our own box and learn from other services and adapt them to what we have in our service and what we can, provide.
Thank you. I have another question, a question for, if no one has a question? No? Okay, for Barbara. We also have a problem of crack market in our part of Switzerland, the Italian-speaking Switzerland, in Lugano. Something similar to what you described. So it's not an epidemic like it was described in the US in the 80s. Okay, so it's important to define this. But it's still an epidemic in our patients. So our patients, mainly patients who were for many years, so aged patients who have been using opioids for many years, now shifted onto crack use. And that means that this is for many reasons. For example, because of price, because of availability, because the pusher that come from abroad use their houses to prepare the drug, as you mentioned. The drug is prepared on site and then sold. And so what we observed is that our patients that are, again, aged with a lot of comorbidity, many of them died because crack cocaine is actually more toxic than opioid if you don't know how to use it. Exactly. Our patients, usually they know very well how to use opioid, and it's very rare that they die for overdose, but for overdose of cocaine they die. Usually probably because of heart attacks or arrhythmia. So is something that you also observed in your setting?
Thank you for the question. It is often not immediately related to the use of the substance. It's not considered in death certificates as an overdose death, which is complicated. We've seen the same a little bit, but not straight away. I mean, honestly, I thought this might be a temporary thing because like in the years 2000, 2001, we had a cocaine increase suddenly in people using methadone, and it was intravenously. And so the hospital was full of people, with abscesses, endocarditis, thrombosis, infections. And it lasted less than a year, and it stopped because people said, oh, wow, this is too dangerous. And then there also was the opening of the safe use facility. So we always said it's maybe related to that. So it decreased. And I thought, this will be the same. We have crack cocaine. They will stop because they will see that they cannot live with it. But no, it's not the case. It's a different type of use. And what we see is in the beginning, we had not so many people dying, but now. And it's slowly because they are losing weight, they don't eat enough, they have the pulmonary problems related to the inhaling, and then probably they die of a heart attack because they're elderly people who have been smoking. We have been several cardiovascular risk factors. But in our data, they don't appear. It's like a natural death, which is wrong. And as I said in my presentation, I think we really have to know better what's going on in monitoring, and because it might help us to explain and to do some education to the people who are using. They know it. They feel it. They say, I know I should stop. We are in this phase now that people are more and more convinced that it's threatening their lives, really, and that they should stop, but we don't have the quick fix. Maybe I think this psychedelics is not maybe the answer either. But it's absolutely true. There will be a huge increase of people in premature death, people who have been able to have, we have been able to work with them for many, many years, and we see exactly the same thing everywhere. And I hope this sort of, hype goes away also.
Thank you.
Yeah, I would have also a question to Barbara about cannabis, because as you showed us, Switzerland was a bit in advance in the 90s with pragmatic decisions for care of substance users. But I'm wondering why we had to wait until now to have projects for cannabis. Do we have some answers about this?
Well, so of course, it's a very complicated question. I think several things are the case. There has been a votation about cannabis that was done at the same time in 2008 as the other votation, which was on integration of the 4 pillars drug policy in the law. And then everybody was so afraid that harm reduction and heroin treatment should not be accepted that we as professionals, we said we are not going to focus on this cannabis issue. So it was refused, and that was in 2008. Even if there was already some experience from other countries that it might be feasible. And then everybody said, well, if you want to do that, you cannot vote again. It has been done, you have to wait. It's impossible to vote this again, and so just wait for 10 years. Now we're already 15 years further, and there have been a lot of things ongoing. The thing is, if you want to regulate cannabis, it's a change in the law, and in Switzerland the system is so that the population has to vote in it, and you really need a long preparation to get this through, and you get signatures, initiatives, and it's a long process. So I think that's the most important reason. Even if a few years ago already, there has been polls that showed that 2/3 of the Swiss population was in favor of cannabis regulation. And I think if we do that again, probably it will be even more now.
Thank you, Barbara. So we reach now the end of our session. So I thank you very much. I thank the speaker, Barbara, Louise, and Lina. I thank the audience for being here. Thank you very much. I'm very happy about the discussion that we had. And please have a good rest of the day.
Thank you. Thank you.